about my bodily functions, for the most part. Maybe sometimes. But in the next few episodes, I'm going to be talking about all of the organ systems that make our lives possible, even occasionally pleasant. And to start it all off, I'm going to go straight to mission control, the nervous system. Pretty much every single animal, except for some really simple ones, have nervous systems, which is great because it's what lets things do things, like have behaviors. It makes you the sentient living thing that you are. The whole setup here, your brain, your nerves, your spinal cord, everything is made up of specialized cells that you don't find anywhere else in the body. Most of those are neurons, which you've seen them before. They look kind of like a tree with the roots and the trunk and the branches. Neurons bundle together to form nerves, pathways that transmit electrochemical signals from one part of your body to another. So when you bite into a piece of pizza, I love it when there's pizza in the videos. The receptor neurons in my taste buds recognize I'm eating something salty and fatty and awesome, and they carry that information along the nerve pathway to my brain. And then my brain can be like, yeah, pizza! And then it can respond by sending back information through different nerve pathways that say, you should eat more of that pizza. And yet, despite what my brain is telling me, I'm going to try to not eat any more of that pizza. You wouldn't think that it's terribly complicated to, know that pizza tastes good and to tell someone to eat more pizza, but it turns out that our brains and our nervous systems are crazy complicated. Your nervous system basically has a big old bureaucracy of neurons, and it's divided into two main departments: the central nervous system and the peripheral nervous system. Central and peripheral. The central nervous system, basically your brain and your spinal cord, is responsible for analyzing and interpreting all of those data that your peripheral nervous system, all of the nerves outside of your brain and spine, collects and sends its way. Once the central nervous system makes a decision about data, it sends a signal back through to the peripheral nervous system saying, do this thing, which the peripheral nervous system then does. Both of these systems contain two different types of neurons: afferent and efferent. Afferent and efferent are biological terms, and they're horribly confusing, and I apologize on behalf of the entire institution of biology for them. Afferent systems carry things to a central point, and efferent systems carry things away from a central point. So afferent neurons carry information to the brain and spinal cord for analysis. In the peripheral nervous system, afferent neurons are called sensory neurons, and they're activated by external stimuli, like the complex and glorious flavor of pizza, and then they convert those data into a signal for the central nervous system to process. The central nervous system has afferent neurons too, and there they bring information into special parts of the brain, like the part of the brain that goes salty. Efferent neurons carry information out of the center. In the peripheral nervous system, they're called motor neurons because many of them carry information from the brain or the spinal cord to muscles to make us move, but they also go to pretty much every other organ in your body, thus making them work and do stuff to keep you alive. In the central system, efferent neurons carry information from special parts of the brain to other parts of the brain or spinal cord. Of course, if it ended there, it would be way too simple, and no good bureaucracy has just two departments. So the peripheral nervous system is actually made up of two different systems with two very different jobs: the somatic nervous system and the autonomic nervous system. The somatic system controls all the stuff you think about doing, like all the information coming through your senses and the movement of your body that it makes when you want it to make movements. But here's something interesting. Since we're totally in love with our brains as sort of the center of all being of ourselves, we think that all the information about everything going on in our bodies goes to our brains for some kind of decision. Not so! Sometimes, like when we touch a hot stove, the afferent neurons carry the signal hot to the central nervous system, but that information doesn't even ever get to the brain. The spinal cord actually makes that decision before it gets to the brain, sends a message directly back to the muscles saying, get your hand off the freaking stove! This bit of fancy nerve work lets the spinal cord make decisions rather than the brain, and it's called the reflex loop. So the other branch of the peripheral nervous system, the autonomic system, carries signals from the central nervous system that drive all of the things that your body does without thinking about them. Your heartbeat, your digestion, breathing, saliva production, all of your organ functions. But we're not done yet here. We need to go deeper. The autonomic nervous system has two divisions of its own, the sympathetic and the parasympathetic. And the jobs that these two perform aren't just different, they're completely opposite. And frankly, they're always vying for control of the body in some kind of nervous system cage match. The sympathetic division is responsible for, freaking out. You've probably heard this talked about as the fight or flight response. In other words, stress. But stress isn't all bad, it's what saves our lives when we're being chased by saber-toothed tigers, right? The sympathetic system prepares our body for action by increasing the heart rate and the blood pressure, enhancing our sense of smell, dilating the pupils, activating our adrenal cortex to make adrenaline, shutting down blood supply to our digestive and reproductive system so that there'll be more blood available for our lungs and our muscles when we have to, run! And even though you're not in a constant state of panic, at least I hope not, I kind of am, that system is running all the time, every day. But right next to it is the parasympathetic division, working hard to make sure we take it nice and easy, dials down the heart rate and the blood pressure, constricts our lungs, makes our nose run, increases blood flow to our reproductive junk, our mouths produce saliva, encourage us to poop and pee. That's basically what we have to thank for taking a nap, sitting in front of the TV, going to the bathroom, and getting it on. So consider yourself lucky you got both the stress response and the chill the heck out response working side by side, because together they create a balance, or a homeostasis. Now, that's what the nervous system does. Next, we have to talk about how it does it. The neurons that make up our nervous systems make it possible for our bodies to have their very own little electric systems. So to understand how they work, you have to understand their anatomy. Like I've said before, a typical neuron has branches like a tree. These are called dendrites, and they receive information from other neurons. Neurons also have a single axon, the trunk of the tree, which is branched at the end and transmits signals to other neurons. The axon is also covered in a fatty material called myelin, which acts as insulation. But the myelin sheath isn't continuous. There are these little bits of exposed neuron along the axon, which have the sweetest names in this whole episode. They're called the nodes of Ranvier, which seems like an excellent working title for the 8th Harry Potter novel, Harry Potter and the Nodes of Ranvier. Anyway, these nodes allow signals to hop from node to node, which lets the signal travel down a nerve faster. This node hopping, by the way, has a name. It's called saltatory conduction. Conduction because it's electrical conduction, and saltatory because saltatory means leaping. Finally, the place where an axon's branches come in contact with the next cell's dendrite is called a synapse. And that's where neurotransmitters pass information from one neuron to the next. Now, think back to, or just go watch the episode that we did on cell membranes, where we talked about how materials travel down concentration gradients. Well, in much the same way, all of the neurons in your body have a membrane potential, a difference in voltage or electrical charge between the inside and the outside of the membrane. You might also remember that this buildup of voltage is handled in part by a sexy little protein called the sodium-potassium pump. Basically, the pump creates a voltage differential like charging a battery by moving 3 positively charged sodium ions out for every 2 potassium ions it lets in, creating a net negative charge inside the cell relative to the outside. When a neuron is inactive, this is called its resting potential, and its voltage is about negative 70 millivolts. But in addition to the pumps, neurons also have ion channels. These are proteins that straddle the membrane, but they're a lot simpler and don't need ATP to power them. Each cell can have more than 300 different kinds of ion channels, each tailored to accept a specific ion. Now don't zone out here, because all of this stuff has got to come into play when a neuron becomes active. This happens when an input or stimulus creates a change in the neuron that eventually reaches the axon, creating what's called an action potential, a brief event where the electrical potential of a cell rapidly rises and falls. When an action potential begins, like when a molecule of sugar touches one of my sweet taste buds, some ion channels open and let those positive sodium ions rush in so that the inside starts to become less negative. With enough stimulus, the internal charge of the neuron reaches a certain threshold, which triggers more sodium channels to respond and open the floodgates to let even more ions in. That's happening on one tiny little area of the neuron. But this change in voltage creeps over to the next bunch of sodium channels, which are also sensitive to voltage, and so they open. That exchange triggers the next batch, and the next batch, and so on down the line. So this signal of changing voltage travels down the neuron's membrane like a wave. But remember, the myelin sheath insulates most of the neuron and just leaves those little nodes exposed. So instead of being a steady wave, the wave jumps from node to node, speeding up the travel time of action potential down a neuron. That's your saltatory conduction at work. When the wave reaches the end of the neuron, it triggers a release of neurotransmitters from the neuron through exocytosis, and those neurotransmitters then float across the synapse to the next neuron, where they trigger another action potential over there. And by this time, so many sodium ions have gotten inside the first neuron that the difference between the outside and the inside is actually reversed. The inside is positive and the outside is negative. And it seems like neurons hate that more than pretty much anything else, so it fixes itself. The sodium channels close and the potassium channels open up. The positive potassium ions rush down both the concentration and electrochemical gradients to get the heck out of the cell. That brings the charge inside the cell back down to negative on the inside and positive on the outside. Notice, though, that now the sodium is on the inside of the cell and the potassium is on the outside. They're in the opposite places of where they started, so the sodium-potassium pumps get back to work, burn up some ATP to pump the sodium back out and the potassium back in. And whew, things are now back at the resting potential again. So that, my friends, is how action potential allows neurons to communicate signals down a whole chain of neurons from the outer reaches of the peripheral nervous system all the way up the spinal cord into the brain and then back out again. So let's zoom out. Look at the broad view here. I'm going to take a bite of this pizza. All of my taste buds have neurons in them. Each of my taste buds contains between 50 to 100 specialized taste receptor neurons. Chemicals from this beautiful pizza dissolve in the saliva and then stimulate the dendrites on the afferent neurons. This generates a bunch of action potentials that travel from the afferent neurons in my tongue all the way to my brain, which is like, my goodness, I think that's pizza. Let's have another bite. The brain then sends messages through the efferent nerve pathways to do all sorts of things. 1, chew, which involves constricting the muscles in my jaw over and over again. 2, lower my head down to catch another bite, which involves moving all kinds of neck muscles. 3, swallowing, which involves constricting the muscles in my throat and esophagus. 4, opening my mouth again to receive another bite. That signal is also going to my jaw. And that's not even to mention what's going to go on with the digestion of this bad boy driven by the autonomic nervous system. But digestion is still a couple of episodes now. Hopefully, there will be more pizza. Thank you for watching this episode of Crash Course and for giving me an excuse to eat more pizza. If you want to review what we learned in this episode, check out the table of contents. Thanks to everyone who put this together. If you have questions for us, Facebook, Twitter, or the comments below. We'll see you next time.
Here we go. We're going to talk about chapter 13 after I had some difficulties, and it looks like I'm having another one again. This would be a reason why you do not want to have a Mac. Okay, looks like we're good there. So chapter 13, the neurological diseases and conditions. This is actually a pretty fun chapter. The overview we just talked about in the video, so I'm going to kind of circle around through that. So we'll talk about the #1 vascular disorder in the United States. Common cause of disability is something that we call the stroke. It's we call it cerebral vascular accident, but they also are now terming it CVIs. They're changing the A from accident to an incident because people can have more than one of these. So this is #1 cause of adult disability. And it can also lead to death. What happens with a CVA, CVI, or stroke, think about when we talked about heart attacks where you have that blockage of an artery. Well, when you have a blockage of blood flow to the heart, then you have tissue death. And so with the brain, a CVI or CVA, also more interchangeably termed as stroke, is the brain attack. So people, like we said, heart attack is the acute myocardial infarction, while the brain attack is a CVI or CVA. So with someone that is having a stroke, it usually reflects one side of the brain. And so both portions can be affected, but usually it occurs on one side. So depending on what side that they're having is when we're going to see the changes. Some people can have a headache, some people can have difficulty speaking, they may have weakness or the paralysis. Confusion is a big thing, loss of vision. It really depends on where that blockage is. And so as you know, the right side of the brain, as we see here, the right side of the brain controls the left side of the body. The right side of the body is controlled by the left side of the brain. So if we have a stroke here, let's say in the frontal area, they're going to have cognitive issues. They're going to have short-term memory loss, speaking more as it goes towards the back, and loss of vision is definitely in the occipital region. So we see different changes based on where they're having that at. Um, with these, it can occur with a couple uh, different etiologies. And so, first one could be a thrombus, which is something that's most common. We have a hemorrhage where the blood vessel actually ruptures, or there could be a fat embolus that actually goes there. Very similar to a heart attack. So, as far as the treatment, there's really not much that we can do if someone decides to call 911 or get treatment after 3 hours of the first of symptoms. So recognition is really important. Once we recognize this, we have only 3 hours to give something that is called TPA, which is a thrombolytic that we give intravenously to dissolve the clot. And so we only have 3 hours to do that. If you think about it, it seems like a long time, but it actually is not at all, especially if we recognize it right away. Um, After that, what you have to do is go to a what we call a stroke interventional center. The ones that exist in the Metro Detroit region are not many. So you can go to Henry Ford Hospital in Macomb, or Clinton Township. So Henry Ford Macomb. They have McLaren Macomb. They are now a neurological um, interventional facility. Other places that you can go to is St. Joe's Pontiac, Providence Southfield, Beaumont Royal Oak, and Providence Novi. What those places will do is they will go in just like they will in the heart. They will go in and see the artery and basically take the clot out and try to restore function as soon as possible. However, this doesn't really fix everything. Their timeline for this is usually 12 hours from 3 hours. Prognosis with people that have a CVA depends on how fast you recognize the symptoms and how quick we can reverse it. So if you wait past those 3 hours and you're unable to do something after even 12 hours, then there's really nothing that we can do. Time is tissue and time is brain lost, and so brain cells are destroyed and we can't really replace them, unfortunately. So with a TIA, this is a term that we term something as a mini stroke. When I think of TIAs, I think of to compare them. Pretty much the mechanism is just like angina. And so with angina, you have that temporary blockage and it causes the chest pain and then it's relieved by nitroglycerin. Well, with TIAs, what this is a temporary blockage. Same thing as well in the brain. It's referred to as mini strokes. They can resemble a stroke. They have the same signs and symptoms. The only thing that happens is within a couple hours, everything is gone back to normal, and then don't have to worry about anything. So these are a precursor to having the big CVI or CVA. Same thing with this. A lot of people will have weakness on one side. They will have the same symptoms as having a huge stroke, but the only bad thing is that it goes away after a little bit. This can be by a piece of plaque, usually embolus. We diagnose it by history and physical, and we got to identify the source. It's usually the common carotid, is where they have a plaque that breaks off in the common carotid artery that goes up to the brain and then passes on to the rest of the body. Treatments depend on the location and cause, so we had to do anticoagulants, make sure they take an aspirin. Prognosis usually comes back, but like I said, this is a precursor to having the big stroke. So here's an example of a small clot. It just goes in there, impedes the blood flow, and then all of a sudden, since these are high pressure, they tend to break up and dissipate and travel throughout the rest of the body. So AV malformations, this is a pretty interesting condition. This is where you have a high pressure artery going. Usually it goes artery to the capillaries and then capillaries go into the veins. Well, there's no capillary bed, so you have a an artery going right into the vein, and so there's a high pressure that goes directly into a low pressure, and this can cause huge problems. Usually where we see this in is younger teenagers, where they have a headache and then they have this sudden loss of consciousness, or they appear like they're having a stroke. And um, what happens with this is it ruptures and then they go unresponsive, and then we do a quick CAT scan and we find out that they're bleeding inside their brain. And so they are fragile and they do have a tendency to rupture, and it's kind of when we catch them, it's usually a fluke. It's usually once they have ruptured. If we catch them via diagnostic scanning, so say someone's had some headaches for a while and we say, well, why don't we do a CAT scan on these people? And we do a CAT scan, we find it, then we're actually really lucky. So there you go. You have a high pressure artery communicating all the way with a vein, and then it tends to rupture. So with epidural and then subdural hematoma, when I think of epi, I think of the word as being fast. So epinephrine is something that's really fast. We call it adrenaline. So epinephrine, with these epidural hematoma, it is blood that collects on between the skull and the dura mater, and so it's the outermost three layers of the meninges. So these are pretty fast bleeding hematomas. Subdural is, when I think of sub, I think of something that's you have a subfloor, and so that's usually below the main house, and so in the basement. So this is blood that collects between the dura mater and the arachnoid, and these are usually slow. So with epidural hematomas, usually you're going to see epidural hematomas from blunt force trauma. The worst epidural hematoma is right on your temporal arteries, so on the side of your head. So my mom always used to say, watch out from getting hit in the side of the head. Well, that's true because you have your temporal arteries and you can actually rupture that, causing a epidural hematoma. So epidural hematoma is going to be on the outside. Okay, and then now you see the dura mater right here. So subdural is going to be below that. Epi, these bleed really fast. These bleed very slow and develop. Same thing here. Epidural above, subdural below the dura mater. Fast, slow. So signs and symptoms for both of them, we have pressure on the brain, either from a hematoma that can result in impaired function of the brain and or death. Usually occur from head trauma, which is the number one cause of these. So with someone that has an epidural hematoma, usually this is fast. So epidural, fast bleeding, they get hit in the head and then they're precipitated by a loss of consciousness, so they pass out. Not good. As they wake up, they have a headache, they have dilated pupils, and they have nausea, vomiting. They have increased drowsiness. If not treated promptly, these people will go unconscious, they will go into a coma, and then they can die. So never a good thing. With a subdural hematoma, the signs and symptoms are very similar. However, it's delayed because slower accumulation, like I said. With subdural hematoma, the people will have gradual symptoms that get worse, worse, and worse. Where epidural is just worse in the beginning and then gets even worse after that. So how we diagnose and treat of these, big thing is history and physical. We look and see if there's recent trauma, including falls. Big thing with subdural hematomas. Falls are what can, usually is what is related to them. So someone will fall down the stairs and then they wake up a couple hours later and then now they're not acting right. It's because they've had a slow bleed that just got worse. So what we do with these is we will do a craniotomy or a burr hole to try to reduce the pressure into the brain. The brain is a closed circuit, so once we have bleeding that's in there, you worry about herniation of the brain, and when that happens, it's pretty much irreversible. So we got to try to reverse a lot of that. With basilar skull fractures, this is something that you see when someone has a pretty significant injury. The only bad thing about this is the common signs that you see, such as bleeding out of the nose and bleeding out of the ears. This is kind of a late sign, especially when we have something called raccoon's eyes, and so this is where they have bruising around the eyes, and then battle signs is bruising behind the ears. Those are usually a late sign. Anytime there's a basilar skull fracture, we worry about CSF fluid leaking, and that's never a good thing, and possibly damage to the brain. So we're going to talk about cerebral concussions and then talk about cerebral contusions. With a concussion, this is related to trauma. It's usually when someone has a blunt force where the head goes back and forth. So they can usually fall from this, or they could have a basically hit in the head by an object. So we term this a contra coup insult. So the head goes back right here, contra coup, and so this means the brain is sloshing back and forth. So you can see this brain is kind of injured because in the back of the skull right here. Usually with these people, they have decreased respiratory rate, their pulse rate is depressed, muscle tone is flaccid. Once consciousness is regained, the person may experience big thing, typical signs of head injuries, blurred vision, photophobia, nausea, vomiting, double vision, never a good thing. With a contusion, this is more serious because with these people, this involves bruising or tissues along or beneath the surface, and these symptoms last longer than 24 hours. So we have a concussion where the brain just gets hit back and forth. Now, contusion, now we're bruising a lot of the tissues, now we're insulting it. So as the head's going back and forth, now we're causing damage each time the brain got moved. So it's on this side, then it's on that side. Never a good thing. So we're talking about paraplegia and quadriplegia real quick. So both of these are spinal cord injuries. With spinal cord injuries, it affects where the level of injury is and below. So the higher it is, then you worry about cervical injuries. You worry about respiratory compromise, diaphragm paralysis. Never a good thing. It's better to have a lower spinal cord injury than it is a higher one, because higher affects everything below. So there you go, fifth thoracic, lumbar, sacral, so forth. So with the difference between paraplegia and quadriplegia. So paraplegia, the way I think of it is when someone is a paraplegic, they're able to push themselves in a wheelchair. So with paraplegia, someone is able to push themselves in a wheelchair. That means that they have use of their upper extremities. It's just below the waist is where they have their paralysis. Now, quadriplegia, this is where they're unable to push themselves in a wheelchair. They have loss of nerve function below the cervical region, and this is a higher functioning cervical spine injury. And it results in paralysis of the arms, hands, trunk, and legs. So quadriplegia is right here. They cannot push. Paraplegia, they can push. These are still working below the waist. And hemiplegia is where we would see in a stroke. So degenerative disc disease, this is where someone has repetitive deterioration of the back. It can be a genetic thing, or it can be usually from wearing and tearing of the body. Herniated and bulging discs, this is usually a ruptured or slipped disc. Usually this is what we call sciatica, usually occurs in the lower portion of this. It can have debility if it presses against any nerves. These are usually corrected by a chiropractor. These are usually the best people to go to. You can have surgery though. If it is really bad, they will have surgery that will go in and remove that portion of the disc and fuse that vertebrae so it's not herniating on the spinal cord, which is causing that paralysis. So migraines, we're talking about migraines are periodic severe headache that becomes completely incapacitating. Usually with people that have migraines, they usually will have an aura before, and so they will have some sort of smell, they may have some sight. Um, Usually it depends on the person, but migraines are never a good thing. Really don't know what causes it. It can be a family thing, it could be a blood flow thing, a vasospastic thing that happens. Women get them more often than they do men, and then usually teenagers to early adulthood. As you get older, they usually just go away. With epilepsy, I have a really nice video on our week 8 section, which I encourage you to watch. There's different forms of uh, seizures or epilepsy. So the different forms that we have is the petit mal. This is absent seizure, usually occurs in young children or young adults. Like I said, I have a really good video on our week 8, which I really suggest you to watch. It's going to be right here for absent seizures and for grand mal seizures. Watch these. These are really good videos that will help you out explaining the difference between the two. So with absent seizures, usually it's really absent. Tonic-clonic, this is a more common. Grand mal is where someone is flailing their arms. This is what we see more commonly. Status epilepticus is kind of just like if we talked about status asthmaticus, is where someone's having a seizure and it does not stop at all, even with medication. And this is a true medical emergency. So when someone's having a seizure, the worst thing that you can do is stick something in their mouth. Never, ever stick something in their mouth. Like I've told you, I give you permission to completely slap someone if um, they try to put, if someone's head is going back while they have a bloody nose. Never do that. Same thing with a seizure. If someone puts something in their mouth, just make sure you slap them. The best thing you want to do is put the person, cushion their head, put them on their side, and let them have their seizure, and make sure you call 911. Never try to hold someone down. Don't worry about them biting their tongue. It usually happens. They're not going to swallow their tongue. Just need to prepare them, make sure that they're not going to hurt themselves or anyone around them. Parkinson's disease is a disease characterized by the lack of dopamine. These people that have Parkinson's disease will have a characteristic pill rolling. They will have shuffling of their gait. They walk pretty interesting, like they shuffle. This is something that we really a lot of people have had Parkinson's disease. We're seeing more people with it. Michael J. Fox, he had it and he still has it. The onset is usually age 60. These people have a stoop posture. The head is bowed. Body is always flexed forward just because of that shuffling gait. It does affect men more than it does women. As they get older, it affects their swallowing. We know this is a deficiency of dopamine, the neurotransmitter. What we see is dopamine in the urine, where they're basically getting rid of the dopamine. The only thing that we can do for it is to provide a drug called levodopa or L-dopa, and it's to replace the dopamine that's being lost. Huntington's chorea is not a good disorder at all. It's basically atrophy of the brain. So you have the normal brain right here, and then with Huntington's chorea, it just has the brain just shrinks. It's usually it is something that's a genetic based disorder. Is passed on by either sex from a mother or father. With people that have this is a person that had Huntington's chorea, then this is what they develop into. They just basically deteriorate right in front of your eyes. Begins in the middle age, and then you basically go to irreversible brain damage. DNA analysis can tell us the family history of it. There's no cure for this, and the only thing that we do is supported treatment. And people usually do die, unfortunately, with this. ALS disease, or Lou Gehrig's disease, is a destructive motor neuron disease that results in muscular atrophy. This is where it starts with fasciculations, and then atrophy of the muscles. So these people usually will, how the paralysis goes, it usually goes from the lower portion up, and so they have difficulty speaking, walking, chewing, and then eventually they will need a ventilator. Um, Stephen Hawkins is the most common person that has, most known person that has Lou Gehrig's disease right now, and he's doing pretty well. So you have the direct action of the neurotransmitters. We think that it's excess glutamate that really blocks this transmission. Inability to have that motor neuron function and transmit, and so is a nervous system disorder. We really don't know what is causing it. We have some sort of prognosis, but right now we're still trying to find a cure. Most normally for the ALS ice bucket challenge that a lot of people have done last year and last 2 years. Transient global amnesia. This is something where people think that I'm having a stroke, for example. But the difference is when people think that if I'm having a stroke, I will not have any paralysis of one side. Usually, I'm just having trouble remembering current events, and so they may not even know what their name is, their birthday, anything like that. At sometimes, but they know their name. Um, I've seen this before, and this was usually people that have this, they have a history of it, and it's not known until you get them to the hospital. Um, we know a little bit about Bell's palsy. Bell's palsy is caused by the tick bacteria of Lyme's disease, also can be caused by stress. Meningitis can be viral or it can be bacterial. What's worse? Um, both. Um, Bacteria is the most, but like I said, it is viral. To diagnosis, we do a lumbar puncture. With people that have meningitis, they will have neck rigidity. This is never a good thing. They have the headache, they have the nausea, vomiting, so forth. Encephalitis is inflammation of brain tissue. You can have sudden onset, but there's a lot of different causes that could cause encephalitis. So we could have it hepatic induced. So liver failure can cause it. Alcoholism is another thing that we will see. Um, it can be viruses or toxins from chickenpox, for example. Mosquito, most common cause of people dying from West Nile virus is um, from encephalitis. So Guillain-Barré or Guillain-Barré syndrome. This is where the body attacks the myelin, but it only does this for about 24 to 72 hours. These people have acute, rapid, progressive numbness and tingling of the feet and hands, and they have muscle pain. It moves up, and so it goes all the way down to the lower half of the body. Then it works its way up for the paralysis of 24 to 72 hours. This is usually an autoimmune disorder. Brain tumors. Brain tumors are never a good thing. My good friend Josh passed away about 2 years ago from brain cancer. And there's different forms of brain cancer, but they are um, never a good thing to have since it's such a close space. Brain cancer can be a primary or it can be a secondary tumor site. Like I said, secondary tumor sites usually with lung cancer. So that is our lecture, quick and short here. What I would do is make sure you watch the different videos that we have here on our blackboard, and then it will help you out through the rest of the homework.